Hi, it's the nursing professor here to give you part two of studying for your pharmacology final. And so we're going to go all the way through our cardiovascular system, which includes cholesterol medications. So we're going to start it from my head, talking about things that affect central nervous system, all the way down to our hearts. And then in the next video, you'll get the other part. Okay. All right. So first, I want to remind you of safe medication administration. Then we need to know three names. We need to know the chemical name, that is the chemical composition of the drug that's usually found on the insert of medication. We need to know the generic name, which is a name that is given to medications based on whatever the FDA comes up with. It's non-proprietary. Example would be acetaminophen. Then we have the brand name or the trade name, which is the brand, like Tylenol. So generic would be acetaminophen, whereas Tylenol would be brand name. All right. So we also have to break it down into controlled and uncontrolled substances. Uncontrolled substances are those that don't pose a risk for abuse or addiction. Whereas controlled substances range from 1 through 4, and they have a high risk for abuse or addiction. Please note that blood products, whether or not they are platelets or FFPs or whole blood, they are infused with only normal saline using a Y connector. You have frequent vital signs given. All right, so let's kick in to central nervous system drugs. And so first ones we're going to talk about is sedatives and hypnotics. And so an example of that is benzodiazepine, which works on the central nervous system. It's frequently used for treatment of anxiety disorders, kind of quieting people down prior to having surgery. It's a muscle relaxant. Sometimes people take it for insomnia, seizures. So it's very widely used. And so examples of that typically end in AM, like alprazolam, diazepam, lorazepam. Those are examples. Sometimes they can also be used for panic disorders. So nursing considerations include sedation, lightheadedness, ataxia, decreased cognitive functioning. We would teach our patients to avoid machinery, be it a car or a lawnmower or whatever it is that they use. But because of that drowsiness effect, we should use it very cautiously when a person has to operate those types of machines. It is considered a Schedule 4 drug. All right, you want to also teach your patient to avoid taking it with grapefruit juice and high-fat meals, because that helps, it messes with the absorption of the medication. But you do want them to take it with food. So the next drug on our list is buspirone, and so that is also an anti-anxiety drug. And with this drug, we have to look at allowing it time to build up in order for it to be therapeutic. Frequently used for panic attacks, social anxiety disorders, OCD, and other anxiety disorders. So at this point, we have our benzodiazepine and our buspirone, okay? Both in that anti-anxiety category. With buspirone, we want to be concerned with telling our patient about the possibility of constipation. So we want them to increase their fiber and their fluids, and it has been associated with suicidal ideations as well. So we want to be cautious of that. Interactions, again, include grapefruit juice. Grapefruit juice, you'll see that it can interact with central nervous system medications and also cardiovascular medications, so we need to be aware of that. Next category is going to be your SSRIs, and these are your antidepressants. SSRI stands for selective serotonin reuptake inhibitors. And these antidepressants allow for more serotonin to remain free. And so the person, if it's free, then the person may be less likely to feel depressed. Examples of those include paroxetine, sertraline, cetiprolol. So it's not like as a separate ending or suffix that I can give you for you to remember those. They do have a long half-life, and so it does take a while to build up in the system. And so that's one of the things that you would teach your patient about, because many times when people first go on antidepressants, then they think it's a magic drug and they're going to feel good right away. Not the case. It does take time for it to build up, and it can be up to 4 weeks. Complications include nausea, tremoring, fatigue, drowsiness, and so we want to make sure that our persons are aware of that, as well as if they have a history of GI bleed. That's the other specific about your SSRIs. Also bruxism. If you remember, bruxism is grinding of your teeth, and so that has also been associated with people who take SSRIs, and you want to explain that to your patient. Then the next class is going to be tricyclic antidepressants, which again, these are going to help people who suffer from depression, and an example would be amitriptyline. And how that works is that it blocks the reuptake of norepinephrine and serotonin. So again, allowing more of those properties to be available, so that hopefully the person won't feel depressed. So the tricyclic antidepressants are not only used for antidepressants, but they can also be used for neuropathic pain, fibromyalgia, anxiety, OCD, insomnia, even ADHD. And so we want to make sure that because of its wide range of actions, that we are aware of that. Also used to treat bipolar disease as well. So nursing considerations include teaching a patient about orthostatic hypotension, and some of the anticholinergic effects, like everything slowing down, like dry mouth, blurred vision, photophobia, urinary retention, constipation. So everything slows down, and so we need to make sure our patients are aware of that. Then next on the list of antidepressants, we have MAOs. And these are your monoamine oxidase inhibitors. Examples would be phenelzine, isocarboxazide, or Z, I should say. And they allow for more neurotransmitters to be released. And of course, the more neurotransmitters we have, then the less likely we are to feel those symptoms. Also for bipolar disorders, remember we mentioned the tricyclic antidepressants with bipolar disorders, but also looking at that class, we want to make sure that we have mood stabilizers when administering drugs for people who suffer from that. And one of the primary ones is lithium. Lithium is no drug. It's a drug that works for some people. However, it has to be used cautiously. And so some considerations would be to look at GI distress, hand tremors, polyuria, which can be very important if a person suffers from diabetes, because you can't tell what's diabetes and what's, I feel like I need to drink. Weight gain, renal toxicity, goiter, hypothyroidism, lithium toxicity, and should not be used for pregnancy. So what we can do with lithium is to make certain that we're taking levels. Usually they start out monthly, and then they can be extended based upon the person's tolerance for that drug. Some of the side effects from lithium can include that this person starts to have some of those involuntary movements, confusion, so make sure that you're monitoring your patient closely. Other neurological disorders, we're going to move away from more of the mental health drugs and move into other central nervous system disorders like Parkinson's and seizure medications. So in Parkinson's, we have to make certain, and seizures, we have to make sure that the medications do have a therapeutic effect. And so one of the primary drugs associated with Parkinson's is the combination of levodopa, carbidopa, sorry. The two of those together seem to work very well for people. There's no cure for Parkinson's. But there are a lot of things that we need to teach with that the patient should teach it with food, start at small dosage, and then start to build up on the doses. They should avoid high protein foods though, although they should take it with foods. Some side effects may include dyskinesias, orthohypotension, and cardiovascular effects like tachycardia, palpitations, irregular heart rhythms. And so because of that, we have to keep a close eye on it, as well as teach families and the patients about these signs and symptoms that they may experience. Next on the list would be your anti-seizure medications, and there are many of those drugs these days. And so we have things like your phenobarbital, your phenytoin, which is also dilantin, gabapentin, carbamazepine, which is Tegretol. And so we want to understand that they are teratogenic with pregnancies, meaning that they could cause harm to the fetus. They are used to control seizures, and when their levels are therapeutic, they do a good job of that. But we have to be aware of toxicity, like a person can have too much of it. And some of those signs of toxicity include ataxia, nystagmus, where the eyes move uncontrollably, respiratory depression. A person can even get pinpoint pupils and go into a coma. So blood levels are super important with anti-seizure, anti-epileptic medications. If any of those signs and symptoms are seen, then the medication should be stopped right away and the provider should be contacted. All right, finished up here. We go into ears and eyes. Eyes, typically we're looking at glaucoma and the beta adrenergic blockers, because in glaucoma you have this high pressure, and so you want to see what you can do to help decrease some of the pressure in the eyes. And so some of the nursing considerations include telling a patient to expect maybe some stinging as they first start to use the medication, to report if their heart rate drops below 60, because even though it's to decrease pressure in your eye, it can have an effect on the heart. Same thing with atropine drops. And storage. Many of the eye drops should be stored in a cool place or a refrigerator, so it's important for people to comply with that. Next on the list are ear disorders. Usually we're using antimicrobials, and we'll do a whole section on anti-infectives. And so with that, we need to make sure that the person understands about GI upset, because as people take antibiotics, then many times people experience GI upset because medicine is killing both good and bad bacteria. Along with that, could be a person could experience a super infection because of all of that destruction of bacteria, that they develop either oral thrush or yeast infections. So we want to make sure that we talk to our patients about that. Let's see, respiratory. Let's quickly go through respiratory. Chronic inflammatory disorders like COPD, asthma would also be one. And so one of the first medicines are bronchodilators that open up the bronchioles and to allow more air into the body. Anti-inflammatories also work, and that is decreasing the inflammation in the lungs or the bronchioles, again, to allow more air in. And then we have the methylxanthines, for example, theophylline. And theophylline is a pretty old drug, but it works very well. However, we need to teach our patients about caffeine, because the interaction with caffeine is not something that we want to have happen. And theophylline works by relaxing the smooth muscle in the bronchioles. So those medicines are very good with respiratory illnesses. So upper respiratory infections, we have your antitussives, your expectorants, your mucolytics, and your decongestives. And so with the antitussives, that's for the person who has this chronic cough that goes on and on and on. Sometimes they're prescribed with opioids and sometimes not, but they really do help with that dry, just nagging kind of cough. Next would be expectorants. This is when you want the mucus to come out, and so you want a medication to encourage that cough. And so that helps to promote lung production of that mucus. Then we have the mucolytics, which also help in improving the flow of secretions. And last are decongestants, which many of us are taking this time of year. It helps to decrease the swelling in the nasal passages, especially for people who suffer from seasonal allergies. And so you're not having that head pressure or pressure in your sinuses. It does help to relieve that. So our next category is going to be cardiovascular, and this can get to be kind of dry and mundane. So just hold the video, go back to it, stop and start, whatever you need to do. So these are medicines that affect urinary output. So these are going to be your diuretics because they are designed to increase urine flow in a person in order to allow the blood pressure to be better controlled. So first step would be your diuretics. And those are going to be things like your furosemide, your butamide, torsemide. And so these can be given orally or IV, and they work to manage the blood pressure by decreasing pressure by encouraging the person to relieve their bladder and get rid of some excess fluid. So things we need to be concerned with as nurses is to make certain that the person is not losing too much fluid, hyponatremia, or hypokalemia. We want to monitor urinary output to make sure that that person is at least given 30 milliliters of fluid per hour. You might want to do daily weights in order to see if the urine output or fluid decrease is working as it's supposed to. Now, with the particular furosemide, we want to be concerned with ototoxicity. And typically that can happen if a person is getting IV push furosemide and it's pushed too fast. And so that's going to be a problem with the hearing. So put that in your memory bank because you can associate furosemide with ototoxicity. Next set of diuretics would be your thiazide, and that's like your chlorothiazide, hydrochlorothiazide. Those are fairly common, and they also work to, of course, get rid of extra fluid. They just work in another area of the kidney. In particular, it's, it's in the early distal convoluted tubule. All right, so those are going to be the IDEs. And so they're used to decrease edema and heart failure, liver and kidney disease, often used with other medications, similar nursing considerations, and that you're concerned with dehydration, hypokalemia, hyponatremia, because the person has this excess fluid loss. You want to do daily weights. Hyperglycemia can also happen because of this elimination of excess fluid. Then the blood sugar can go up, and so we want to make sure if a person has that as a problem that we're monitoring their blood sugar. All right, so then we have potassium sparing diuretics, and these are diuretics that work similarly, except they do not have an impact on the potassium. And so this set of drugs blocks the action of aldosterone. So an example would be triamteride or amiloride. They're frequently used in heart failure. We should monitor the potassium to make sure it doesn't go the opposite way, be too high, greater than 5.0. And because of that, then of course we will be monitoring for dysrhythmias, because anytime we have an elevated potassium, we could have dysrhythmias. Treatment is usually to stop the drug, and then it usually will subside. We also have osmotic diuretics, which decreases intracranial pressure. Many times are used with brain injuries where you have that increase in pressure. Also can be used with pulmonary edema. And so an example of that drug would be mannitol. which is infused with a filtered needle because you need to avoid the crystals that actually form. So if you use a filtered needle, change the needle, then put on a new needle, then you're minimizing the likelihood for that to actually happen. You do not want to use mannitol if a person has an active intracranial bleed. Other blood pressure and cardiovascular system medications include ACE inhibitors, which are your angiotensin converting enzymes. They're used to treat hypertension, heart failure, MI, and they end in pril, P-R-I-L. So that's going to be your enalapril, your lisinopril. And so what you want to be concerned with these prils is that sometimes people have taken these drugs for many, many years and suddenly they become allergic to it. So you'll see, full-blown anaphylactic reaction to it, especially lisinopril. So you want to make sure that you tell your person to report any signs or symptoms. Let's see, you want to monitor for a dry cough. Frequently, people do complain of having a dry cough, as well as hyperkalemia. And again, knowing anything associated with hyperkalemia, you have an increased risk of the dysrhythmias. Those are abnormal heart rhythms. It's not a good idea to use it with pregnancy. Next set of drugs would be your angiotensin II receptor blockers. These work by blocking angiotensin II. And so they end in TAN, T-A-N. So that's going to be your irbesartan, your candesartan, valsartan, drugs that end in T-A-N. And so what we're concerned with is angioedema, that a person has that reaction to taking the drugs, hypotension, the blood pressure goes down too low too fast, dizziness, lightheadedness, fatigue, just having no energy at all. It's important with any of these medications that the nursing consideration includes teaching, because there's so many drugs on the market or classes of drugs that most providers can find an alternative that is better suited for your patient. We also have aldosterone antagonists, and these work by decreasing blood volume by blocking the aldosterone receptors in the kidneys. And so, of course, they're used for hypertension, heart failure, PMS even, because sometimes you have women that have such suffering with PMS that their bodies will retain a whole lot of fluid, and so that needs not to happen because blood pressure will go up. Nursing considerations again include the hyperkalemia, and so anytime we got hyperkalemia, we have the likelihood of dysrhythmias. You can also have hyponatremia with this set of drugs, flu-like symptoms, dizziness, fatigue, menstrual irregularities, because remember we're talking that it can be used for people who suffer from PMS. Then we have the direct renin inhibitors, and it's just that. It directly inhibits renin production. And so what happens here is that this is another way of relieving hypertension. Nursing considerations would include hyperkalemia, diarrhea, hypotension, looking at drug interactions when they are used, especially when they're used with other drugs. And they frequently are prescribed, not solo, but with other drugs. We also have calcium channel blockers, and these are going to be your nifedipine, your verapamil, your cardizem, amlodipine, and these drugs are frequently prescribed, and they work to block calcium channels in blood vessels. They lead to vasodilation of vascular smooth muscles, and so therefore the blood pressure does decrease. Can also be used for angina pectoris, that is many times unexplained chest tightness, pain, hypertension, and cardiac dysrhythmias. We have alpha adrenergic blockers, which are the sympatholytics. Now, these are drugs that were originally used for hypertension, but then they noticed that it can be used for those who suffer from BPH, or benign prostate hypertrophy. And examples would be doxazosin and terrazosin, frequently prescribed for BPH. And their action is that they dilate both venous and arterial. So you can imagine that if a person has this hypertrophy, male has this hypertrophy, that's going to impact their ability to urinate, have erections, and things like that. Then having that dilatation could possibly help. Symptoms of somebody suffering from BPH would include urgency, frequency, dysuria. When they take the medication, you want to tell them to change position slowly because you can be concerned with hypotension, dizziness, faintness. Then we have centrally acting alpha agonist, which includes both alpha and beta receptors, and those are drugs like clonidine. Clonidine has found itself in being used in things other than the blood pressure. Also used with managing hypertension, cancer pain, opioid addiction, management of ADHD. It can produce drowsiness, sedation, dry mouth, and rebound hypertension if abruptly stops. And so you must instruct your patient on that. We also have other beta adrenergic blockers, and these are drugs ending in LOL. So this is y'all's language, LOL, laugh out loud. Remember that. All right, so that's your metoprolol, atenolol, and esmolol. So these are beta blockers, and so typically they work to slow down the heart rate. And this is treatment for people who have unexplained tachycardia, or they need to slow down the heart rate. They need to decrease the myocardial contractility and the rate of conduction because everything is sped up too much. When we look at drugs in the same category like propranolol or nadolol, those drugs affect both the heart and respiratory system. All right, and so with propranolol, because it does affect the respiratory system, you want to avoid it with somebody who has respiratory problems like asthma. Can be used for people who have hypertension, angina, tachycardia, of course, heart failure, and an MI. You also can have carvedilol, labetalol, which are both alpha and beta blockers as well. So the main thing with all of these drugs, these blockers, don't abruptly stop them. Really, not many antihypertensive should you abruptly stop. But know that one of the big side effects from it is a slow heart rhythm. All right, let's talk about hypertensive crises. So these are drugs that we have to use in case of an emergency. So the first one is going to be vasodilator like nitroglycerin. We also could have drugs like nicardipine, which is a calcium channel blocker, and enalapril, which is an ACE inhibitor, or esnolol, which is a beta blocker. So all of those are potential drugs we could use for hypertensive crisis, meaning that they act really quickly. And so with nursing considerations, we want to make sure that we administer these drugs slowly because going too fast can make the blood pressure drop too quickly. We want to monitor both the blood pressure and EKG and have that person supine while they are receiving the drugs. Okay, then we're going to talk about digoxin, which is a cardiac glycoside, frequently used with heart failure. Also can be used for irregular heart rhythms. And so it works by increasing the force of the myocardium contraction, and it works to decrease heart rate. So frequently used to treat heart failure, and dysrhythmias like afibrillation. What's important is for us to monitor digoxin levels, monitor potassium, because sometimes that potassium will start to creep up with using digoxin. It does interact with many medications, so we need to be aware of that. Side effects can include nausea, vomiting, abdominal pain, anorexia. And a classic sign we associate with digoxin is blurred vision, and people frequently say they see like a halo. And so that is one symptom to associate with digoxin. All right, then we have your adrenergic agonists like epinephrine, used in an emergency as well. It works to vasoconstrict. So we would use this if a person is experiencing shock or massive bleeding or hemorrhage or something like that, because we need that constriction. It also is used to slow the local anesthetics. Sometimes it's used for that, and it can be used for managing superficial bleeding as well. With that, the heart rate increases, myocardial contractility can increase, cardiac output can as well. So usually epinephrine is one of those emergency drugs. Also used with bronchodilation, like in an asthma attack. So it's going to constrict cardiovascular wise, but it does open up, dilate the bronchioles in order to allow that person to breathe better. Another drug that we have, these two work kind of similarly. They're used both in critical care, is dopamine and dobutamine. Dopamine works with the renal blood vessel dilation, frequently used with heart failure, shock, acute kidney injury. And so it works by increasing the myocardial contractility. We want to make sure that when we're administering these drugs that the person's on continuous cardiac monitoring. So we're monitoring for dysrhythmias and making sure that there's urinary output. Dobutamine is a beta-1, frequently used for heart failure. It increases heart rate, myocardial contractility, and cardiac output, used in a hypertensive crisis and cardiac complications. So one of the things to note about dobutamine is that necrosis can occur if that IV does infiltrate. And so many times you don't want a peripheral line. You might have to use one as an emergency until you can get a central line started. But extravasation can happen, and that can cause necrosis of the vessels and skin. And so to counteract that, there's a drug called phentolamine that's used to counteract that. Next process we're going to think about is angina or angina, where you have this many times unexplained chest pain that people experience, and we use nitroglycerin for that. It can be taken in an extended relief capsule. It can be taken as a patch or a paste placed onto the skin underneath the tongue sublingually. If it's taken sublingually, you're going to give it to a person 5 minutes apart times 3 doses. And it can also be given IV. Okay. Side effects include a headache because everything is starting to dilate, orthohypotension, drops tolerance, and reflex tachycardia. So you want to use it cautiously. Antilipemic agents, which are your cholesterol-lowering medications, they include the statins, like atorvastatin, simvastatin, lovastatin, where they work to decrease your LDL, which is your bad cholesterol, raise your HDL, which is good cholesterol, and some of them have an effect on the triglycerides, but some of them don't. Simvastatin is thought to have some impact on your triglycerides. Complications include hepatotoxicity, because that's the area of the body where it's metabolized, and sometimes people complain of muscle pain. And so you want to listen for those symptoms from your patient. You also can have cholesterol absorption inhibitors like ezetimibe. It inhibits the reabsorption of cholesterol secreted in bowel and absorption of cholesterol. So although a person might have a funky diet, then it's going to help to minimize the absorption of the cholesterol. Remember, cholesterol comes from anything that comes from an animal. So all your meat, cheese, eggs, all of that. You also have bile acids, sequestrants, which you add to water, or you can add to food, and so they work to decrease the LDL, which again is the bad cholesterol, which you have to be concerned with. Sometimes people do complain of constipation with that. The fibrates, which include the gemfibrozil, which is used to decrease triglycerides and LDL, so bad cholesterol and triglycerides, and increase your HDLs. And so that's a good thing because that helps minimize a cardiovascular risk. With that, people sometimes complain of GI distress, myopathy, hepatotoxicity, which again, processed in the liver, and that muscle pain, weakness that some people experience from taking these cholesterol medications. Coagulation drugs are going to include your blood thinners. That's going to be things like your heparin, warfarin, Lovenox, Eliquis, those types of drugs. And so with heparin, it works to prevent clotting. And the lab test to evaluate whether or not heparin is working on that is a PTT. Whereas with warfarin, it's a PT. Warfarin is by mouth, heparin is either sub-Q or IV. The antidote for heparin, if you have a toxic level, is to give a person protamine, and you want to look out for bleeding, bruising, GI bleed where you might not see, but you can see melena in the stool, and make sure that your person knows to use it cautiously. Cautiously with aspirin or ibuprofen. Vitamin K inhibitors would be your warfarin. That's the PO form of a drug similar to heparin. And so it's going to work to prevent the coagulation, which is what you want with a blood thinner. It prevents venous thrombosis and PEs, also used with afibrillation. Lab tests to monitor that again is a PT-INR. Usually they want the levels between 2 and 3. Vitamin K is administered if you're at a toxic level. Antiplatelets, these are going to be things that prevent platelets from forming, so clumping together. And so that could be aspirin or Plavix. Those are the two top ones. So they do alter bleeding time. The thrombolytic medications would be alteplase, or also known as TPA, and that drug is given in an emergency. The key with that is you have to know when the symptoms began. So if someone has a stroke and they come in and the person with them says that the symptoms began 4 hours ago, then they can get that TPA, which will help that stroke from continuing to evolve. Used with strokes, MI, massive PEs, and TIAs. Okay. Blood and blood products, as I said at the top, are used for replacements. Make sure you're only infusing with normal saline. You have a Y connector. You have frequent vital signs. If you have an elevated temp, stop the infusion. Infuse normal saline, and contact your provider. So that is it for now. The next set will start to talk about GI and bones and skin and things like that. Bye for now.